Hey, I think we can go ahead and get started. Hello, everyone that's joined already. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. So my name is Autumn Sipis. I am a project manager for the Canadian Coalition for Green Healthcare, and on behalf of the coalition and Peach Health Ontario, I would like to welcome you to today's Cut the Carbon Beyond the OR session, evidence-based planetary health prescriptions. And I'll mention for those of you who aren't aware, our Cut the Carbon Beyond the OR sessions are monthly. I'll put my email in the chat if you would like to receive regular notifications for those. But if you already signed up for the coalition's newsletter mailing list, then you should already be receiving those. So throughout the event, please use the chat function for any technical issues you may be experiencing and use the Q&A function for any questions you have regarding the presentation today. We will be recording this event, and the recording will be sent to all registrants and be available on our YouTube channel at a later time. So presenting today, we have Dr. Valerie Palda and Dr. Nabha Shetty. Dr. Palda is a general internist at St. Michael's Hospital, Unity Health, and oh, this is a big word, epidemiologist, specializing in clinical practice guidelines. Beyond the hospital, she is a regenerative farmer who has seen firsthand that human health is inseparable from the health of our planet. She works within her department and with the Canadian Association of Physicians for the Environment to find practical and collaborative ways to implement interventions that have been shown to improve both patient and planetary health. And we have Dr. Nabha Shetty, who is an associate professor with the Department of Medicine at Dalhousie University and scholarly activity director for general internal medicine. Nabha is active in national planetary health leadership through co-founding the Canadian Society of Internal Medicine Planetary Health Task Force, developing Choosing Wisely, Canada's climate-conscious recommendations for internal medicine, serving as an advisor for the Canadian Coalition for Green Healthcare, and she's on the Royal College's National Advisory for Planetary Health and on Health Standard Organization's Technical Committee for Acute Care to inform accreditation. Thank you both for being here, and I will hand things off to Nabha.
Thanks, Autumn. Welcome everybody. Today we're going to be talking about prescribing for patients and the planet. So how to integrate non-pharmacologic interventions into your clinical practice. And thank you for the kind introduction by Autumn. With just a couple of disclosures. Dr. Palda is the planetary health lead for the Department of Medicine at University of Toronto and has received innovation grant funding for her Growing Sustainable Physicians project involving her regenerative farm. I'm a volunteer advisor for the Canadian Coalition of Green Healthcare and work in the realm of sustainability and quality improvement. And as mentioned, I co-authored the Choosing Wisely Canadian Society Internal Medicine Climate Conscious Care recommendations, and I've received some grant funding from our Department of Medicine at Dalhousie for our initiative called the Greener Medical Teaching Unit. So our objectives today are to scare you into the way that you practice medicine. I'm just kidding. Well, I'm not actually. So let's get into it. What is climate change? So climate is the weather in a particular region when it's averaged over many years. Climate change is the shift in average weather conditions. And this shift that we have all been experiencing now has major implications for healthcare. In fact, many have stopped saying climate change and are actually just calling this the climate crisis at this stage. So the background to this is that we, as the human race, have made tremendous public health gains since the 1950s. So we have dramatically improved rates of global child mortality and our life expectancy. But in the meantime, we've been doing so and disrupting the Earth's natural systems. So the anthropogenic environmental changes that have occurred, anthropogenic referring to a term that means the human actions effect on nature, is we have shifted our biodiversity by destroying forests and ocean environments. So there is very little biodiversity left in these areas. We're changing biogeochemical flows. We've changed the way that we use land, where most of the land that is now used is for animal agriculture, where it used to be wild land. Of course, we know that we've had rising rates of global pollution. All of this is changing our climate and depleting us of natural resources. So if we look at consumption patterns, you can see that after the 1950s, consumption patterns start to rise, and they rise quite exponentially, like logarithmically, in the amount of water we've been using, the amount of energy we've been using, the amount of plastic and paper that we've produced. And we map this great acceleration, as it's known as, onto what's been happening in our natural systems. So since the 1950s, we've also seen a dramatic increase in the degradation of the Earth's biosphere. We've seen massive amounts of fish being captured, carbon dioxide being released into the atmosphere. The ocean's acidification has been on the rise, and we've lost a lot of tropical forest land. In essence, what we've done is we've mortgaged the health of future generations to realize economic and development gains in the present. And this is a quote from the Rockefeller Foundation's Lancet Commission on Planetary Health, which was released in 2015. So this is that scary graph. What this is it's depicting the shared socioeconomic pathways. And they've got 5 projections here. So this was a global coming together of climate, political, business leaders in 2021 to develop these pathways. And you'll see that the blue lines, the light blue and the dark blue lines, represent shared socioeconomic pathways 1 and basically 1.9 and 2.6. And what that is that this would be the whole world kind of waking up to the reality of the climate crisis and deciding that we're going to stop doing what we've always done, and we're going to, decarbonize our economies. We're going to grow food and change the way we consume. Everything is going to have to shift, and that is going to curb that global warming effect of the average temperature of the Earth, where we've kind of already hit that 1.5 degrees in elevation in Earth temperature. We want to kind of mitigate that rise to keep it controlled to under 2 degrees. In contrast, the red and the brown pathways would be continuing to do what we're doing already. It would be ongoing investment in fossil fuel-based economies, in the military-industrial complex, fast fashion, animal agriculture, all these things that we've kind of become accustomed to being the norm. We wouldn't change any of that. And then nations and populations would start fighting for resources. There would be increasing conflict, plenty of climate refugee issues, migration due to climate issues. And as you can see, all of this consumerism and extraction and warming is going to result in a very different state for the global temperature, where you're looking at rises of up to 4 to 5 degrees Celsius. And what that really means is that a baby born today is facing extinction, because this is just 75 years from now. But as you can see in the graph, I'm not sure if I have a pointer, but we are right in the middle there. We're at 2026, so right between 2000 and 2050 there. This is where the paths diverge. So the future is still, to an extent, in our hands. So everyone's scared. But the good news is that taking action alleviates anxiety. So we're going to show you how you can take action in the face of this overwhelming climate crisis. Let's start by defining what is planetary health. So planetary health is the construct that recognizes the interconnectedness of our health with the health of the planet. So arguably the health of the individual is connected to public health, and public health is connected to global health. Global health is connected to One Health, which includes both the health of humans and the health of animals. And planetary health is just an extension of this concept to include the health of the planet as a whole. So it includes the health of natural systems, the ecosystem, and all living things that we share this planet with. This recognition that the health of the planet is connected with the health of humans is becoming a growing concept in healthcare itself, where now we have the quadruple aim for healthcare improvement has integrated advancing planetary health into its model, where they have substituted out public health for planetary health, recognizing that the climate crisis actually is a public health crisis. So health systems are more and more acknowledging the importance of protecting our earth systems in order to preserve our own health as humans as well. I'll just say one more thing. I don't have a slide here, but many people aren't aware that the healthcare system and the way we practice medicine today is actually very polluting. So the healthcare system in Canada is responsible for about 5% of Canada's carbon footprint. This is double that of the aviation industry. And we are, as a health system in Canada, that is on the extreme higher end of carbon cost. Per capita, it's actually about 100 times more than Eastern healthcare, like in India or in China. So we are extremely wasteful and extremely polluting the way that we practice medicine. And ironically, it's not because we deliver better quality care necessarily. It's actually because we haven't ever made this link until more recently. Now we are starting to recognize that waste is not just without harm. Wastefulness in the system actually actively harms our patients. So we're going to start with a practice case. So I want you all to meet patient A. This is a 58-year-old person with type 2 diabetes and mild hypertension. Currently, patient A is feeling isolated because they recently retired. They spend most of their time indoors with a sedentary lifestyle. Their diet is fairly high in processed foods, including processed meats. They have a clinical goal that they want to improve their glycemic control and they want to improve their blood pressure, but they don't want to take more and more medications while doing so. So the long-term goal is to reduce the need for medications, but still have good control over their underlying health conditions. So this is our challenge. How can we treat patient A while also reducing the environmental footprint of their care? And this is why planetary health matters right in the clinic. We have to recognize the interconnectedness. Human health and the health of our environment are inseparable. Sustainable healthcare means that we know how clinical choices, such as the medications we prescribe, the waste we generate, where we're referring people, and how often, whether we're keeping them out of acute care, et cetera, all of this affects the ecosystem, which in turn affects public and societal health. So this is our opportunity. Today, Dr. Palda and I would like to show you 4 non-pharmacologic prescriptions that are proven to improve patient health, to save money, and to reduce greenhouse gas emissions. So the first one we're going to talk about is exercise prescribing. So if we bring it back to the practice case, our patient has issues with mobility and frailty. So patient A has been driving for all their errands. They take the elevator even for just one floor to get up to their apartment. They exhibit early signs of frailty where they have decreased bone density. And they're really worried, though, about the cost of a gym membership. So this isn't an easy fix for them. So, what's the evidence behind giving patient A prescription for exercise? Well, we know that exercise prescribing can promote patients finding ways to integrate exercise into their routines, and this has upstream benefits in management. The clinical benefits of exercise prescribing are that it helps with metabolic syndrome, which our patient is facing as well with the type 2 diabetes and hypertension. It also helps with osteoporosis because of increased muscle strength, which protects the bones. And in turn, all of this helps with frailty. The system benefit of exercise prescribing is that it has been shown to actually reduce resource intensive acute care utilization and admission. Now, when I gave you that 5% stat of carbon footprint of healthcare, the vast majority of greenhouse gas emissions that make up that statistic are coming from acute care utilization. So keeping patients out of hospital, even one day, has massive impact in reducing emissions. And this is where the Planetary Health Link comes in. In addition to reducing the need for acute care utilization and hospital admission, which is in itself linked to planetary health because of emission reduction, encouraging our patients to participate in active transportation like walking or biking will also reduce travel-related emissions, which is a more direct way of reducing emissions, all the while building their physical fitness and reducing issues like frailty, osteoporosis, and metabolic syndrome. So the evidence level for exercise prescribing for these various things is that there are prospective cohort studies that support patient benefit as well as the system benefits. And the planetary health benefits would be extrapolated from those things that I shared with you, the acute care resource utilization reduction and the active transportation. So here is a sample exercise prescription. Take a post-meal walk. So 10 minutes of timed walking after every meal. So have this happen 3 times a day, and then you get your 30 minutes of walking in. Walking after a meal also has been linked with better glycemic control because the muscles eat up all that sugar rather than just hanging out in the vasculature. For strength training, which is relevant for osteoporosis risk reduction, choose an exercise of choice of resistance training for about 20 minutes, 3 times a week. And then adding in that active transportation piece might just encourage people to use the stairs instead of elevators or walk or bike for short trips when possible, rather than using the car. Next, we're going to move on to social prescribing. So here's the practice case again. Our patient A is socially isolated since retirement. They lack a sense of community. Most of their time was spent at work previously, and now they're lonely. And this loneliness is contributing to poor diet choices, a lot of screen time, and a lot of lack of motivation to exercise or get out. So how do we bridge the gap between the clinic and the community? The evidence for social prescribing is growing. So we have studies from Ontario itself that show that referring patients to community-based resources actually reduces emergency visits and hospital admissions. As was the case with exercise prescribing, the more we reduce reliance on hospital-based care, the less we emit greenhouse gas. So the Planetary Health Link for social prescribing is largely based on reduction of acute care utilization. Through reducing acute care utilization, it's been projected that a family practice of 1,200 patients would avoid almost 4,000 kilograms of greenhouse gases emitted annually. Social prescribing can be done either through integrating a link worker into a health home or a family practice, or clinicians can directly refer to social programs. So on the right here, I've got an example of a social programming that's available to me. As an internist in Halifax, I can refer patients to this Northwood, which is a long-term care site, but also runs these community programs. So as you can see, there's a whole bunch of different stuff that probably meet different needs for your different patients. So there's trivia nights, there's games afternoons, there's chair yoga, ukulele club. My gosh. So there's a whole wealth of social prescribing opportunities out there if you know where to look for them. And these can have upstream impacts of reducing hospital reliance and improving quality of life, and ultimately also helping planetary health. So here is our example social prescription. Join your local walking group or participate in the neighborhood community garden and enroll in a plant-based cooking class. And you're going to learn more about the importance of community gardens and plant-based cooking classes as I turn over to Dr. Palda.
Thanks, Nabha. Hello, everyone. I'm going to talk to you about two other strategies we have with the prescription pad for non-pharmacologic interventions that can help. The first one is nature prescribing. I'm going to leave the diet prescribing to last, but the nature prescribing is something that I think, as physicians or healthcare providers, might not think of as a formal thing to offer to patients. The isolation and immobility that Dr. Shetty was talking about, and also the hypertension, can be affected by this. So the patient A, who had become increasingly housebound, we know that, or we'll talk about the evidence for this, but going into nature addresses obviously the sedentary habits because you're going out, you're maybe going for a walk, and then it'll provide psychological enrichment and mental health well-being. If you invest in nature, similarly, so it invests in you. So that reciprocity of actually taking an active role, either just being in nature, connecting to it, remembering what's important to you, like what is your favorite place, creates a link that many of our city dwellers don't have. And even just the specific suggestion of walking or biking to the local site then also increases the amount of exercise you have. Next slide, please. So specifically, what evidence do we have to support this? I mean, we all agree it's a good idea, but you can reduce somebody's systolic blood pressure by 5 points and improve anxiety and depression by nature interventions. There's a large systematic review that looks at this, and we're talking hundreds of studies, and they sort of narrowed it down to the 40 best studies, and there's quite a lot of evidence to support this. Participation in a community garden. I'm interested in growing things, and I looked into this, and then the participation in the community garden specifically will improve psychological outcomes. So depression, anxiety, stress outcomes. And that also allows the patient to engage in social activities. It also improves food security. So just like a medication might have more than one benefit, so similarly, this intervention might have more than one benefit. So the cohort studies, the RCTs, support the patient health benefit, and prospective cohort studies show planetary health benefit for this particular intervention. And again, you want to try and be specific and achievable, your SMART goals. As with other behavioral interventions, it's path, not, it takes a while. Here we have a picture of my husband swinging on a vine in New Zealand, enjoying a little forest bathing. Next slide, please. So if you took out your prescription pad, you would want to maybe say 20 to 30 minutes per day in a green or blue space. So green would be what we were familiar with the forests and the park. But blue space, such as water, can have a therapeutic effect as well. And our goal is ambitious. It's 120 minutes per week. But I think that if you combine it with another thing, like if you're walking for 20 minutes per day and achieving that 150-minute goal per week, you're similarly achieving this goal. And any activity has been, like any of these activities have been shown to be helpful. The meditation, again, in the context of a natural space. Equity-wise, there's some issues which we will address in a future slide. So I'm going to talk about those in a minute. Next slide, please. So here is our patient again, and I think this is not just patient A, I think it's patient A, B, C, and D in our practices. We have a lot of, sorry, I just want to make sure I'm not missing any questions. So we have a lot of high risk eating taking place. And I particularly work in an urban setting, and we have a lot of people who are under or not housed at all, or they're in shelter systems, and eating healthy is a real challenge for a lot of people. But in our particular patient's case, even being housed, being alone, it's hard to kind of get motivated to cook. And so you opt for your hyper processed foods in different settings, cultural settings. Bread, meat, and potatoes might be the thing. And if you don't know how to manage cooking, then it's a lot harder to make it fun and switch what you're eating. And then there's just the chemical benefit of hyper-processed foods have been developed by chemical food scientists to be really good. And so as a result, they're very much easier to eat. So different behavioral strategies include things like, rather than taking away, adding a serving of whole grains, pulses such as lentils or beans. That adds fiber, which decreases your cancer risk. It adds a slower release carbohydrate, which modifies your glucose. It's easier to take a half cup of something and put it in there versus saying you can never eat in donuts again. And then specifically targeting, let's say, 2 days that are meatless. And in order to achieve this, talking to the person who's actually doing the cooking is the most effective strategy. So in a family practice, having that other family member might be critical. You have to be very mindful that there are specific cultural practices. So can you make your recommendations within that? Often, if you're not a dietitian, you may not feel confident making those specific recommendations. We're good as physicians at recommending disease diets like DASH because of the salt and the hypertension contribution, portfolio diets to reduce cholesterol, but just shifting everything towards plant-based recommendations has multiple synergistic health benefits. Next slide, please. So if you, so the evidence is like overwhelming, and I've been really surprised by it in the last couple of years. But it is really impressive what shifting your diet can do. So there's weight loss, which everybody loves, but that's not the primary, actually. The reduced insulin resistance is quite dramatic, improved lipid metabolism, reduced all-cause mortality, and a reduction in medication use for diabetes and hypertension. The sort of worst offender are the processed meats, and they're considered class 1 carcinogens. They increase your risk of coronary disease. And then as you shift towards plant-based, those provide the anti-carcinogenic phytochemicals that are very helpful, as well as the fiber and obviously the nutrients. Like a lot of my patients, I'm finding are very magnesium deficient. I don't actually know why that is. I have a lot of coexistence of substance use and alcohol, so there is some contribution from that, but it may be that our diets are just less nutritious than they were. And shifting more towards plant-based can improve that. Often there's the concern of B12 deficiency. There's something called a B12 supplement. It works really well. And so don't let that scare you. And protein is not an issue. Okay, elephants eat only veggies. Gorillas eat only veggies, and they're big and they're strong. We can get enough protein with a plant-based diet. I am not there yet. Dr. Shetty is. I just want to show you our picture here. My picture, this is me for the first time cooking tofu. And I made a pulled pork tofu. So sometimes getting some skills helps transition. Again, adding rather than taking away. And you can see that there's some black beans there too. So, and then my indulgence, which is the corn chips. So you have to kind of go slow, and it is possible. And I think what's important for healthcare providers is to understand the evidence base is very strong. And then we've got like RCT level evidence supporting patient health benefit and the planetary health benefit as well. Next slide, please. So how does that translate into a prescription? Ideally, you get to no red or processed meat, specifically no processed meat as a first step, and then red meat as a second step. You aim for 2 days, a week of meat, dairy, egg free, and understanding that if we all did this, that curve that Dr. Shetty showed you would be starting to decrease quite dramatically. So the Statistics Canada survey from 2022, I think, is listing 90% of Canadians as eating meat on a regular basis. We have low-hanging fruit here. Adding lentils, beans, and tofu is another specific prescription you can add. A B12 supplement when you are no longer eating meat. Dairy contains B12, cheese contains B12, so you have to kind of track that a little bit. And encouraging the patient to take time to take a class, which again has social benefits, is really useful. Next slide, please. So I had talked about equity in prescribing. I think that the evidence is pretty clear on showing us that people live in green deserts, they live in food deserts. Our inner city residents, are new immigrants, people who have not originally been born in Canada or are racialized. They face unique hurdles in terms of the nature programs. They don't necessarily have a car. They may not live near a park. The park may be dangerous. They don't want to go there. And then social programs are either overprescribed or not known. It just recognizing that they face these barriers allows us as providers to start to specifically, ask them, what do you know is available to you? What would you be interested in? What is culturally appropriate for you? And I when I was treating heart failure, we were trying to improve our heart failure outcomes, and the heart failure nurse was like, "We've made this fridge magnet," and I'm like, 30% of my patients don't have a fridge, so that will not be useful. We could put it on the park bench, but we have to target our interventions to our patients. And so you, as the provider, will know best what your patients need. And I think that the next slide, please. So what's our responsibility as clinicians? I think we don't hesitate to say we are interested in improving patient health, both in our clinic and outside. We've taken a large advocacy role. The Physicians Against Nuclear, I'm not going to get that group's name correctly, but they won the Nobel Peace Prize because they were concerned about the risks of nuclear weapons. The physicians have long played an advocacy role in smoking cessation, advocating for policies that for against advertising and specifically changing what our young people were exposed to. So physicians' roles are not just in the clinic, and also I think we need to realize how effective we can be collectively. So advocating for increasing nature through tree planting programs near our patients, supporting food system changes that increased food security, also increased plant-based options. I mean, our voice is important, where we work, to say, are we using plant-based, even just asking that question, why do we need beef on this catering menu, can make a huge difference. And then pushing for infrastructure that supports our active transportation. This is always a challenge. Like, I live in Toronto, and we have had like this battle just even trying to keep bike lanes. So it's always a challenge, but physicians' voices are very important in here. So I'll leave that slide. I think that's it. Maybe next slide. Okay. Do you want to take this one, Dr. Shetty?
Oh, thanks, Valerie. Okay, sure. Right. So let's come back. It's been 6 months of non-pharmacologic prescribing for patient A. Now, patient A walks to the community garden, which provides nature as well as social, as well as exercise. And through doing this, blood pressure has dropped by 6 points. Their A1C has stabilized. They've also made dietary shifts. They've reduced red meat. They're driving less as well. And through all of this intervention, they've saved money. And they've also, in turn, reduced their annual carbon footprint significantly. So here's our conclusion and our call to action for all of you. Sustainable healthcare is within our reach. We want to argue that non-pharmacologic prescribing is a high impact, low cost tool that you can clearly see is massively beneficial for patient and planetary health. So we ask you, or we invite you to start with one green prescription this week. And we'd like to end our formal talk and open up the floor to questions and discussion. Thank you. Autumn, do you
Actually, this is actually where I hop on.
Okay, thank you. Very good.
Speaking of grasshoppers, Nabha.
I know. I was going to put my costume on, but
So I've thrown you a softball. I meant to throw that to you a little bit before you were finished, but that just landed. If you want to take a look, I am curious. You've offered a few. They're clearly they are not mutually exclusive, but
no, they're interconnected, as is everything.
Yes. So what's your favorite, both of you?
Diet. No brainer.
That was easy. That was it. So
I'm
you're both
obsessed
saying
with food. Yeah, so
okay.
I can tell you that the whole plant-based thing for me has been the hardest and the most rewarding thing to do.
Yeah. Diet for me because I mean, there's so much dialogue around like the affordability of plant-based and all this stuff, but there's like, you think about it, lentils and beans so cheap. So as long as someone has access to a can opener, often you can improve their plant-based intake and like reduce calories coming from like harmful sources, honestly. And then it just has that like feel good impact. Nature prescribing, I think, is like a close second for me. Absolutely. Exercise prescribing is probably my worst because it makes me feel like the biggest hypocrite. But plant-based, like plant forward diet prescribing, I think just checks so many different boxes with respect to like patients can actually save money, they feel better, they also like silently are healthier, like all that like cardiovascular risk and cancer risk. um, and it's just like better for animals, it's better for the earth, it's better for everyone. So that's my number one.
So that it sounds like a slam dunk. There was no hesitation there for either of you.
I'm
And look,
I,
and I wouldn't disagree. I've never actually thought of it myself, but
I think you like
um,
nature, don't you? Because you're the tree planter.
well, yeah. Look, I do. Obviously, I do like nature. I mean, exercise would be up there as well. I mean, that one's obviously been around for a long, long time. As it might be
It
the
has.
first prescription we
I
used to give. Yep, go
I
ahead,
also think that
Val.
growing food is going to become increasingly like victory
Yeah.
gardens were a thing in the Second World War. We used to grow like 80% of our fruits and vegetables in the 60s in Canada. And of course, that's changed quite a bit. But I just think even if you're coming to Canada, often you're coming from an area where it might be more rural and and you feel empowered if you can grow your cultural products. And we've seen this time and time again. I'm part of a farming organization, and there is a huge movement of small scale farmers from other countries who are growing for their communities to provide things like okra or vegetables that are just not commonly available, Asian vegetables. And it's really like, it's a fantastic community building thing too. So people may not think of it, they may be
Yeah.
discouraged by the
I
long
think that's
winter.
also like that would be the reciprocity piece.
Yeah.
Like that land-based healing, that indigenous method of land-based healing, like that reciprocity piece. I think I don't know if anyone's read Breeding Sweetgrass. I really like that book. It just like opened my eyes to so much value of the reciprocity of nature, and with nature, about how important that is for our own health and well-being. Where if you're growing food, you're taking care of land, you're kind of, it's a natural process, and that actually, I think, directly impacts our own health as well. I mean, it's been shown to reduce cortisol, which is where that hypertension effect comes in, like reducing systolic blood pressure through cortisol reduction of just spending 20 minutes like amongst trees or like in the garden. Oh, you're muted, Valerie.
Sorry. There's a question in the chat, which is, would you like me to address that, Miles? How do we approach the subject of plant-based diets with patients that often been raised on a meat and potatoes diet? So I think that's a really good question, because I have a test patient. My neighbor is an 82-year-old farmer. He taught me how basically a lot about farming, and he's a meat and potatoes guy. So I'm like, I test my little theories on him, and he grows his own vegetables, obviously, and there are certain vegetables that he likes and certain vegetables that he doesn't like. So I would say, um, people who have grown up on meat and potatoes are often accustomed to the idea of some kind of bean at some point, maybe increase that in the diet, and then gradually take away the red meat part, or certainly the processed meat part. Often people who are rural will understand meat coming from one of their neighbors. So that meat, maybe they could shift away from red meat and just get chicken from their neighbors and gradually change that whole diet, but in a way that's still acceptable to their rural community. So, and I think you'll find, like, often as people who have grown up in a rural community and who are growing vegetables and fruits in their own gardens, as they become more elderly, might not be doing that anymore. So connecting them to other people who are growing in their community might be a way for them to get access to those types of vegetation as well. And they'll often have some wisdom around freezing in the wintertime that that they haven't used lately. So just even a reminder of, did you used to eat more vegetables, might prompt them to shift.
There's also like there's also evidence that processed plant-based proteins, like the meat substitutes, are healthy. Like there's an argument that's kind of spun by industry that these are ultra processed foods, they're not good for you, but that has not actually been the outcome when it's been looked at from a scientific lens. I think there's a trial that compared processed meats, processed meats, unprocessed meats, and plant-based meats. And the processed meats were very clearly harmful. The plant-based meats were not harmful. I think the unprocessed meats and the plant-based meats might have been kind of equivalent. Although I do think that probably, like, I routinely eat like Beyond Meat and stuff, because it's like kind of a easy, quick way to get plant-based protein in. And there's not, like, it doesn't have to be whole food plant-based right up front, which I think is kind of scary for people to picture just like completely transitioning. So there are these meat alternatives that are plant-based in nature that do not have a body of evidence to suggest that they are actually harmful, that they have the same kind of carcinogenic effect or the same cardiovascular risk.
Okay. So if you're both able to see the chat there, then I won't do the Vanna White roll. You guys can just jump right in. I don't know if there's any more.
Yeah.
One thing I'm curious about, and I don't think there's any evidence on this, but maybe so probably more anecdotal. And the last time I looked this up was about a year ago. I know a family doctor in Hamilton who prescribes plant-based eating, and she would say that she can look a patient in the eye and tell them it's important, and they'll just go off and do it. Now, I don't have that kind of impact on my patients per se, you know. Uh, what is the uptake when you have this conversation? Do we have any idea of what the uptake is in actually changing someone's eating habits?
I think that's a commonly identified barrier, which then makes us say, okay, we're not going to do it. So I don't have the number for you, but I can tell you that if you tell a patient to stop smoking, you just say those words. I'm sure you know this as a family physician. Saying those words reduces mortality by 3%. Because some of those people will take your advice. Some of those people will go through the quitting process. Some of those people will die less often. And those words reduce your mortality by 3%. Does saying eat less meat reduce your mortality? I don't think we have evidence for that, but there are behavioral interventions. Now, we don't have to work in isolation. If somebody has like prediabetes and you say, hey, you're going down this path, do you want to go see a dietitian who would help you? Then the dietitian will have a lot more experience on behavior change than we will. And they might be able to provide the practical way to get there if you've given the advice or prescription. So I would say that any behavior change is hard. It doesn't stop us from saying stop smoking. It doesn't stop us from saying start exercising. So why can't we just use those other interventions as well?
I've had like probably more than 50% of patients make a change in their diet. I basically diet prescribe for every single patient that I see in clinic at this stage, because it's like the most rational, evidence-based, helpful thing that I feel I can do. So I'm non-pharmacologic prescribing way more than I'm pharmacologic prescribing at this stage. This is in clinic, so like in inpatients, of course, like everything's about drugs. But like when I have the opportunity in clinic, I've been doing this like routinely now for a couple of years. And I'd say 50% of patients have made shifts. A small minority, like 10%, have made dramatic shifts. But more than 50% have done some change.
Yeah, not easy to study, but gosh, no, I'd love it if you tried to look at your own numbers.
Like
So,
through a manual review of,
Yeah, I
of
know, I
like my
know.
dictated
How
notes.
do
Oh
you even
God.
do it, right? It's self-reporting.
Yeah.
I
Yeah.
wanted to just thank the commenters because I think this is really cool. Like there's people there's a horticultural therapist, which I think has
Amazing.
probably I think that's the best job description I've ever heard of. So Becky, I'm jealous. I declare that.
Wow. Yeah,
And for kids especially, it's wonderful. And then somebody else mentioned, Taya mentioned that her heart rate has improved from being in nature.
that's right. Less cortisol. That would make sense.
Um, so does anyone else have any comments about what they're doing or what their interests are in or what their challenges are? Because we do have a couple minutes left.
Yeah, are people able to speak, or is it only written commentary?
We can allow people to speak if they wanted to raise their hand, and I can allow them to speak.
Great. A forest bathing retirement plan.
Oh, that's wonderful.
Amazing. Wonderful. Yeah, I'm sure there's a wealth of knowledge amongst the participant group. Would be so nice for people to share their experiences. Anyone brave enough to do so?
Oh, Susan has been plant-based since 1991,
Oh,
when it
wow.
wasn't easy, I'm sure.
Yeah, that's amazing. We didn't really talk very much about social prescribing or exercise prescribing. So social prescribing, I think, is becoming a bit more chic, maybe. Like, actually, the first time I heard about it, Miles, is when we talked about it when we were writing the article. And then I started seeing it everywhere I got. I went like all around me because I knew to look for it.
And by social prescribing, you mean specifically the programs that we're talking about?
Yeah, I think that I think I think it would be low utility to just write like join a group. I think it would be much better if you have this link worker system, or if like as prescribers, if we had a program to direct the person to.
We've got a couple extra comments too in the chat.
Yeah. So we have bike helmets and get comments, hopefully good comments for the bike helmet. And tie out
Caroline,
boxes of
what's that
sustainable
audio?
services. Did someone say something? Or no, was that AI?
Possibly.
Yeah, I think that was some background, something.
Well, thanks everyone for this opportunity. I don't know if Miles, if you're okay for us to wrap up.
Yeah, absolutely. Thank you both so much for coming today on I think, a busy day for both of you. It was an excellent presentation.
Thanks for having us.
And we're happy to get any questions. If you think of anything later, or if you're facing some challenges, it helps me kind of learn where we should be working.
And it looks like someone had asked about the slides. Do we typically send those out to participants?
Yeah, if you guys are good with me sharing them with the registrants, I will send that along with the registration link. So if you guys want to send me your slides, I can do that for sure.
Okay, just to note, we didn't put a reference list in there. Um, but actually, Valerie, Miles, myself, and Owen Luo, another physician, recently published an article with this whole framework. So a lot of the references are just in
You
that.
could send that out as well, I guess, Autumn, potentially.
Yeah, I was gonna say I can definitely send along the article as well.
Okay,
Oh,
excellent. Thank you,
great.
everyone.
Okay, thank
Good
you.
day, good weekend.
Thank you guys. Take care, everyone. Bye.
Bye.